everyone. Welcome back to another episode of the Deals for Dentists podcast. I'm your host, Dr. Eric Block. Through these podcast episodes, I'll be interviewing dental professionals and companies from across the industry. I like to find out people's journey into dentistry, as well as their successes, failures, and advice for helping other dentists and entrepreneurs. My goal is to inspire, entertain, and educate you on the best tools and technologies out there. I want to help make your practice and career more profitable, efficient, and most importantly, more enjoyable. Today I'm joined by Dr. Mike Miyasagi, and our topic today is all about the newest generation of curing lights and bio-regenerative restorative materials, which can help create longer-lasting restorations and give you more predictable results. Mike and I also discuss the subject of stress and burnout in the dental profession. As always, I hope you enjoy the episode, and if you haven't already, consider subscribing to the Deals for Dentists podcast on your favorite podcast platform and our weekly newsletter so you don't miss any of our upcoming shows. Today, we are joined by Dr. Michael Miyasagi, and he is the COO and CDO of Vista Apex Dental Materials. Thanks so much for joining us, Mike.
Oh, great. Thank you very much for having me. And it's so great to have guys like you that are doing things like this. I really applaud you. And I think it's funny, we were talking about it, but stress-free, I guess a stress-free life in dentistry is almost like an oxymoron, right? But it's really cool to be able to be with you and your viewers and to be able to share some information. I think I've learned a lot just talking with you for a few minutes. So thank you very much.
Oh, thanks for joining us. Mike, tell me all about how you help dentists.
These are the things that for me are kind of exciting because I've now been in practice, a high stress practice now for over 30 years. And so we've taken care of multi-generations of families. So we had the great-grandparents, the grandparents, the parents, and now we've got the kids coming through. And I think one of the things that I've learned over 30 years, and we talk about stress-free dentistry, is that when we place a restoration, we as dentists think, oh, this should last for forever. And sometimes we say this is your permanent restoration. And when we see that restoration go and need replacement 5 years down the line, 10 years down the line, or even 40 years down the line, we think, well, why didn't that last? And sometimes we see that great gold work that we did 30 years ago. They barely even teach that in dental school anymore, but we see those great gold restorations. And they've gone 30, 40, 50, 60 years in some cases. And I go, wow, that was so cool. But even sometimes when we cut those off and the margins look so perfect, burnish down to the natural tooth on the enamel on the outside of the tooth, when we cut those gold restorations off, sometimes we'll see that black scuzz or we'll see recurrent decay that's gotten underneath the margin. So that's always been the bugaboo, is we can have a restoration, whether it be direct or indirect, and it could last for decades. But we get that microscopic leakage of bacteria underneath that restoration that just kind of, is the demise of the tooth. And so again, having practiced now for 34 years, what I've seen is we'll have that young child that comes in and we want the best for that child. But kids invariably, they eat sweets, they drink the sodas, and when they go home, they're not the best at brushing or flossing. And so now we have regenerative pit fissure sealants, and I'll go more into what that means, but we place that on the occlusal surface of the tooth to try to avoid occlusal decay. And then over time, typically between birth and maybe 10 or 12, they get their first interproximal caries, and we have to go in there and repair that with a filling, typically a direct composite. Well, when I'm cutting into that virgin tooth, I'm thinking, oh, I hate doing this, but I got to get that decay out. And then when I put my restoration in there, I'm hoping it's going to last. Again, like we talked about, it's a permanent restoration that'll last forever. But invariably, that kid continues to eat the sweets and the sodas and all the, the sports drinks and everything that have the sugar in them. And they're not brushing or flossing any better than they did, a few years ago. And maybe mid-teens or maybe early 20s, we go in there and we have to replace that. Well, now that restoration gets a little bit larger because we have to take out the old restoration and the area of decay. And so we see this kind of repetitively in our practices. We put that first restoration in, it gets replaced, and eventually it gets big enough that we have to go to a crown or an onlay, something a little bit more to reinforce the structure of that tooth. And then we place that crown, and we do everything we can to avoid sensitivity. And then the patient calls us up, and this is one of those areas of stress. It says, ever since you did that crown, which cost me more than $1,000, and I've been having pain on that tooth. So what do? We do our pulp test, and invariably the pulp has died because of all the trauma that tooth has gone through, not just in preparing that tooth for the crown, but for the last 30 or 40 years of that patient's life. And so now they have to have a root canal, and then invariably they're not brushing or flossing any better yet, even though now they're 40, 50, or 60 years old. They get recurrent decay, as we're talking about, underneath that indirect restoration. And we either have, if we can catch it early, maybe we do a new crown. But many times, and I saw it last week where I had to extract the tooth. So we went from trying to prevent the decay with our pit and fissure sealant to now that small, early incipient decay with the class 2 that progressed to crown, root canal, and an extraction. And now maybe we place an implant, bridge, or a partial denture. But after 30 years, just watching that occur, it does get to be kind of stressful, because I, as a dentist, think I should be able to fix that. I should be able to help my patients avoid that. And sometimes it's just frustrating because we can't. And we do everything we can at our hygiene recare appointments. We remind the patients, hey, you got to brush, you got to floss. And it's just, I think, one of those burdens that we as dentists sometimes take on. I'm helping my patients avoid, the demise of their tooth. I'm trying to encourage them, and we get discouraged, I think, sometimes because we lose the battle. So what Vista Apex has done is we've taken some of the science that was developed in the late 1960s. There was a Dr. Larry Hench who was working down at the University of Florida. And at the time, he was doing investigative work on ceramics, and actually ceramics for the use in space. And it's kind of ironic, since this week we had the first kind of suborbital space travel by Richard Branson. So we've got the billionaires going up into space. But back then, Larry Hench was developing ceramics that could withstand the radiation, the heat of space travel. And the story goes that he was, during this conference, he was in a bus, and he was sitting next to an Army colonel that had just gotten back from Vietnam. And, the horrendous injuries that the soldiers were experiencing over there, and they were trying to graft limbs and body parts back together, and they were getting rejections of the body parts. So this Army officer asked Dr. Hench, hey, can you develop something that that can withstand the body itself? So Dr. Hench, actual research was funded by the Army, started in the late 60s and kind of progressed into a product in the 70s, and it was called Bioglass. And what was found is you could take this Bioglass and you could place it on the bone, and it would actually encourage the bone to actually regrow. And so the Bioglass could be like a framework, and the body would grow over that framework, replacing all the Bioglass. And the way that it was doing it is it was attracting calcium and phosphate and actually creating hydroxyapatite that was the bone. So that was in the 70s, and you would think, well, it seems like it would make sense. Well, if we were able to create hydroxyapatite, which is actually, makes up a large part of our teeth, why didn't we try using Bioglass? But it was just a few years ago that this Apex, as a company, using that platform that Dr. Kenka developed, along with our chemist, Scott Lamoran, who is also now the CEO of this Apex, but he is a chemist, and they took those adhesives that were well proven out. So we had the bond strengths. But what we now wanted to do is we wanted to create something that actually helped the tooth heal up. So they took some Bioglass and added it to the adhesives and to our composite, our flowable composite. And by doing that, now we have something that will help us create direct restorations in our pit and fissure sealants that will attract calcium and phosphate and help the tooth. So teeth invariably are exposed to an acidic environment. And so we lose calcium and phosphate. And what the Bioglass helps is it attracts calcium and phosphate and fluoride back to the tooth surface. And so we actually see the regeneration of the tooth structure. And another nice property of this is if we're placing these materials into, let's say, a class 2 restoration on a molar or bicuspid, well, where do we see where's the most common area that we see the recurrent decay? typically at the gingival floor. There's like a little micro gap down there, and the bacteria gets trapped down there, and it's hard to floss and brush down there. Well, if we place our composite flowable lining material, our regen material down there in an open sandwich technique, so it's exposed to the oral environment, it actually helps to keep that area more alkaline or basic. So if we throw acid at that area, the bioglass actually helps to neutralize that acid so that it can't demineralize the tooth. So we neutralize the acid, but if the acid does affect the tooth and demineralize it, the bioglass actually helps to remineralize that tooth structure. So there's a zone of inhibition and remineralization that's created where we see the most common area of defect, that gingival floor margin. And we've had independent research done by Dr. Nate Lawson that kind of showed that this actually did occur. So our internal research showed this. Our third-party research that we're having done in different parts of the world actually confirming this. So, we're very excited about this. Maybe we've got the material now that can last much longer than our direct composites of today. And one of the common things that we get asked is, well, aren't there other bioactive materials? Well, there are, but the way that they work is you have this bioactive material, but it's not good at sticking to the tooth. So you still have to place an adhesive, your regular non-bioactive adhesive over the tooth, and then you put this bioactive material over the top of that. And that bioactive material will work in some way to have some kind of exchange of ions to help the tooth kind of heal itself. That's all good, but I think of it as like having a cut. We were talking before you got started, Eric, you had your kids you're at home able to enjoy that, which is great. Now, if your kids are running around you and they fell and they scraped their knee, how would you take care of that? We know that there's bacteria that could enter that wound. So we'd want to put ointment down and then put a bandage over the top to help that ointment stay there. Well, if you look at the past bioactive materials, what they told us to do is, well, seal the wound at first. So it's like putting the Band-Aid on first and then put your bioactive material over the top of that. So it's like putting the Band-Aid over the wound and then trying to put the ointment on the outside of the bandage, hoping that ointment would have some kind of effect to help that wound heal. Well, today what we're able to do is, because we had the Regenerative Universal Adhesive, we're able to put that right down into the dental tubules. And if you look at some of the other products out there, there's other products that have utilized the bioglass in toothpaste. And what they found is that the toothpaste with the bioglass actually helps, the bioglass helps to occlude the dental tubules and reduce sensitivity. So if we can take that bioglass and allow it to lay down into those dental tubules right over that injured tooth surface, and then we put a reservoir of bioglass, that flowable composite liner over the top of that, now we're getting the best of all worlds. We're putting that healing bioactive glass right into the tubules, and we're covering that up with a large reservoir, that flowable composite that can then neutralize the acids that's exposed to. So, we've got a lot of great promise in this. And, I think, will it get better? It will always get better. But I think this is a great start. And the research is just showing that we get that great zone of inhibition right at that gingival floor margin. And then one more thing that, if I could take another minute, is
sure.
The pink wave curing light. So the pink wave curing light, in my 30 years of dental practice, we've gone through all these iterations of curing lights. We had the old halogens, and, we had that blue light that would come out, but we never knew how intense it was. We never, the bulb would start to burn out. We'd see the blue, we'd cure the composite. And many times that blue curing light, even if the bulb was starting to get weak, it would still cure the surface. So we'd cure the top, we'd scratch it with our instrument, say, oh yeah, that's cured. But we really weren't able to get down into the deeper layers. And if we didn't get into those deeper layers, the patient would have sensitivity. You'd have recurrent decay because you didn't seal that margin up, with a nice set composite down there. And then we went through the lasers and all the different ways of curing. Well, what the pink wave curing light does now is it brings what we call quad wave technology into it. So it's different because all the curing lights of the past were typically going to be blue in color. Well, this one is actually pink. We have red LEDs in there, and the near infrared and the red and the ultraviolet and the blue, those four different wavelengths. What we have found is we actually get a deeper depth of cure up to 8 millimeters. We've got this really large head that's about a 12 millimeter head. So you don't have to do multiple cures. If you're trying to, let's say, cure a molar onto a tooth, it covers the whole molar, the occlusal surface. So if we're doing an anterior veneer, it covers the entire tooth. So it saves you lots of time. But what we have found, going back to the recurrent decay issue, is that if you've got let's say a class 2 and you're curing it from the very top, when the curing light hits the top, it cures that composite and then it has to penetrate down. And we always get shrinkage and shrinkage stresses applied to that composite. With the quad wave technology, and especially that near infrared wavelength, what we're finding is there's less shrinkage stresses being placed on the composite. So again, another reason why we think we can get a better seal down at that gingival floor. And if we can get a better seal down there, there's less chance of recurrent decay. So again, for myself, having now practiced for over 30 years and having seen how we've had to replace our permanent restorations over time, and just the anxiety that creates, looking for solutions to help us prevent all that is really what Vista Apex is all about. And how we get there is we listen to clinicians. So we're not a huge company. We're a company that's been around historically for decades now. So we're not going away either, but we're nimble enough that we can listen to clinicians and take their ideas and their concerns and actually try to develop solutions to relieve us of those challenges. And hopefully that just means we're actually relieving clinicians of some of the stress that they experience day in and day out.
Wow. You said a lot there. And I mean, that's amazing. I mean, I wanted to go back to your, you just mentioned such a common flow of what happens with we're the same way in my practice. I see kids, from the ages of 3 to elderly, the ages of 93. We see them all, and we'll see, the 6-year molar we seal. Then, maybe or maybe not, they got a cavity, or like you said, they went off to college and their hygiene just goes out the window, and they're drinking all the energy drinks, and they come back and it's like, what happened? And all of a sudden they have all these class 2 cavities. Yeah. And you do an interproximal filling, class 2 or class 3, then they get recurrent decay and you have to redo it. And these fillings get bigger and bigger. And then ultimately you have to do a crown. That crown could end up in endo. The endo could fail or the tooth gets cracked, and you're talking about an implant. So you just mentioned such a common kind of lifeline of especially a first molar. So you're really trying to go ahead.
I was just saying, you've seen the same thing too, huh?
Oh yeah. And I, especially when the patient is 40 or 50 or 60, I'll tell them, look, you have had this tooth since you were 6 years old, and it's been through a lot of wear and tear. Usually when I mention that, and I show them a picture of the big cavity or big filling or the crack lines, and I tell them they need a crown, saying that, and with that picture, then usually we're on the same page. And I always warn them of endo, but it's never fun when they come back and they have pain. So, the fact that you're trying to kind of just either prevent all this from happening, or by placing that first filling with these regenerative aspects to prevent that, those further restorations, I think that is awesome. So let's go to the regen. Is that like a system? Like, do you have a flowable, a pit and fissure sealant? Can I get like the whole kit with instructions, so I can have my whole armamentarium for sealants and composites?
Yeah, we have, it is a system. It's a kit. And I think going back to the offer for your group, it's going to be 10% off, whether it be the Regen kit of adhesives and flowable composite liner, or the Pink Wave, or both. But yeah, it's extended over all that. And it is, we call it the Regen Universal Adhesive. And I think one thing, going back to technique, is that it's a universal adhesive, and that you can use it to bond your composites, your lift-end bisilicate, your Emax crowns, even your zirconia. So it's universal, and it'll stick to all the different substrates. Where it's not universal is some adhesives out there will say they're universal if you can do toll etch, selective etch, and self etch. Well, the interesting thing about regen, it should make sense to our viewers here, and hopefully it strikes a chord, is that it is not self etching because we can't make it acidic. Because remember, the bioglass always neutralizes the acidity. So, so if the viewers here are going to use it, we have to condition the tooth some way, some kind of acidic treatment, phosphoric acid, which I'll come back to that in a second. But one of the cool things is that it can't be acidic, because if we add acid to it, it just neutralizes the acid. And I think that's kind of one of the cool things about this being universal. But going back to how we treat the tooth, talking about innovation and just having fun, is at Vista Apex. I know a lot of those that are viewers right now might use phosphoric acid, and some of the phosphoric acids that are out there are the gels, and typically the majority of the time they're blue. Well, we just launched a new etchant called Velvet Etch, and the biggest difference is it's a 40% phosphoric acid, but it's purple in color. And I don't know, the purple color just kind of gives us this rich, kind of this fun feel to it, and it stays right where you put it. So those of your viewers that are selective etchers who just want to get the etching on the enamel and not have it spread all over the dentin, this does a really good job at that. It stays right where you want to put it. But then if you're a toll etcher, it spreads out really nice. So if you take, if you squirt it onto the tooth, you can spread it out or take a micro brush and spread it out, and it rinses off really, really easy because it's got a surfactant in it. So it's really kind of a cool etchant and just something fun because it has that rich, deep purple color. And so we just tell the clinicians, talking about stress is every once in a while, it's nice to think you're using something that's kind of a luxury brand, but it doesn't cost any more than the blue stuff. It just looks nicer. And then another thing that we have just on the innovation side is we have what's called Clean and Boost. So for the viewers that maybe are doing something with the self etch, you can actually, Clean and Boost is it's an acid primer for the tooth, but what you do is you scrub it onto the tooth, and it's nitric acid, not phosphoric acid. And so those of you that are self-etchers, if you use Clean and Boost before you use your self-etch adhesive, your bond strengths will actually go up over 30%. So it's just it's a more gentle way of treating the tooth. And if we're using regen, what I do is I use Clean and Boost, and I place it onto the tooth, the dentin, and the enamel. I let it sit there for 20 seconds and rinse that off before we apply our regen. So it really is a system, and the Clean and Boost comes in the regen kit.
Okay. Does it come with one of those little colorful manuals? I love those where the little images of how to do it.
You know what? I'm trying to think if it has the colorful images in it. Don't hold me to that. I'm not sure. I have to look that up.
Yeah, I need to go step by step.
Yeah, we've got the directions for use, but I know everybody likes kind of the diagram, so you don't have to read the words, right?
Yeah. I don't read the words. I just like to see the pictures. Okay, so you have the Clean and Boost. You do that first, and then you go with your adhesive, and then the flowable. And do you also have a composite that you finish off with?
We actually do at Vista Apex. We have a composite called Exquisite, which I really like. But we've really designed this system where the doctors can place their favorite sculptable composite over that flowable liner. So it's not, we don't include a composite in the kit because we want the doctors, we all seem to have our favorite sculptable composites. Some are a little creamier, some are a little stiffer, depending on what texture you like to work with. So the kit is just designed for that bioactivity against the dentinal tubules, open sandwich technique. So at the floor of your class 2, that gingival floor margin has a nice bulk of flowable there to resist the acidity that area is exposed to. And then over the top, you can place your favorite composite.
Yeah. So let's get to the pink wave, because you mentioned that it had an 8mm. Did you say an 8mm cure, or the head is 8 millimeters?
So it's the head is about 12 millimeters in diameter, but the depth of cure is about 8 millimeters. And it's actually focused down about 5 millimeters down. So, your class 2 box, that's where we really want to make sure that we get that composite cured well. So the maximum beam is really focused down at that gingival floor, because most of the time that's going to be about 4 to 5 millimeters from our occlusal table. So you just get that curing light down there, and it's going to focus the maximum curing right at the gingival floor to get the maximum benefit.
Do you recommend coming down from the occlusal, and then once you remove the band, then doing also the buccal and the lingual?
Yeah, that's what I do. What I do personally is I'll remove I use a sectional matrix. So I'll take that off. Then I'll actually remove any flash that may be around there. So I use an interproximal carver of some sort. And I just remove any flash if there is any. And then, I come in from the buccal and lingual. I think it's still good. I think it could be overkill though, because the pink wave is just delivering so much energy to that large area. I don't think it's really that critical. I think it's more of habit. I still do it.
So I could essentially get an entire molar with one cure.
Correct. Yeah, because the head is so large. And, in the past, when we had, like, if I was doing a veneer case, I'd have maybe 3 passes at a central, the gingival, kind of the middle, and the incisal. Yep. Most centrals are about 11 millimeters in length. And so if you take a 12 millimeter curing head, you get the whole central one cure. So it can cut your curing time by 50 to 60% because you cover so much all in one fell swoop.
And how long is the cure?
Usually I cure for 10 seconds. 10 seconds is what we recommend.
Awesome. Yeah. I cure. It probably takes me, 60 to 90 seconds to cure. So that's, you're saving a lot of time there, especially when you have, multiple restorations going on in the same visit. So, tell me about your dental journey. How did you become a dentist? Tell me about your practice.
Yeah, no, I think it's kind of an interesting story. It's one of those things that everyday dentistry just kind of happens to you. And then one day you're 30 years down the road and you kind of look back at it and go, wow, we've really been lucky on the road that we've traveled. So I started in dentistry 34 years ago. My father was a dentist, and I had an uncle and cousins that were dentists. And so it may have seemed like a natural path. But probably like a lot of us, we got into dentistry not even really knowing what dentistry was about. Even though my father was a dentist, and I'd go into the practice and just be around that atmosphere every once in a while. I didn't really understand what dentists did. And I remember the first few weeks of dental school, I went down to USC and they were telling us we were going to have to learn how to carve teeth. And I was thinking, why do I have to carve teeth? I just went in kind of blind. But I enjoyed it. We got out of dental school. I was able to go work with my father, and then I was influenced by other mentors to me. I got into following Peter Dawson's philosophy of comprehensive dentistry. So after taking Peter Dawson's courses, I actually broke away from my father's practice and wanted to start my own. Kind of had my own philosophy of practice, as many of us do. I think it's one of the freedoms that dentistry allows us to have, is we can practice the way that we feel comfortable practicing. So I actually left my father's practice, and some were telling me at that time, why would you do that? Why do you want to spend more money to have your own practice? It was just something I wanted to have. So I got into doing more comprehensive cases. Then I started teaching and got into education 30 years ago. Taught at LVI for over a decade. And so I was doing live patient treatment programs, working alongside dentists who brought their patients in, and just really enjoyed that. And then after about 12 years of doing that, I went back into private practice. And then when I went back into private practice, I got involved on the corporate side. So I kept up private practice, kept up teaching, lecturing on different topics. And then I started working with different companies, some great companies like Discus Dental back in the day, over a decade ago, Danville Materials. And today I'm working with a company here that's a great company, innovative, lots of energy, Vista Apex. So, kind of been doing a lot of different things, and I really appreciate that dentistry has allowed me to do this. I've been to countries to teach, like Russia. I was in Russia, and I was thinking, I would have never have thought that dentistry would take me to Russia or Australia or Kuwait or so many different countries. And I think one of the things that I've really come to appreciate is no matter where you are in the world, dentistry is very much the same. And our colleagues globally are very much the same, challenged with the same challenges that we all have every day. And we're all trying to find those solutions to make our lives less stressful. And I think that's why it's so great that you're kind of bringing this to the forefront. And I think as dentists, we should acknowledge that what we do day in, day out is very tough. And I think, sometimes we look at other dentists' work and we think, well, I could probably have done a better job than that. But, we don't know what the situation was that day. And like you're saying, we've got to be on top of our game every day. And I think as a profession, if we respect each other and we work alongside with each other and we share ideas with each other, I think that's what's going to really help us reduce our stress. And I think I shared it with you before. I think we have to accept that it's a tough profession. Not everything goes perfect. Every class 2 doesn't go perfect. Every class 2 doesn't last forever. And even if it doesn't, we're always trying to do our best. And nobody goes in thinking, I hope that, I'm trying to figure out how I can not do a good job on doing that class 2 or when I do that crown. We're always trying to do our best. And some of the clinical situations just make it difficult for that to happen. And I think if we can accept that, then it takes a lot of stress away. And, if I think one of the hard things about dentistry is many of us are still working in these solo practices. And so we always think, we read the journals and we look at all the videos and we look at everybody's successes out there and we look at the speakers and we think, wow, they must be having 100% success. It doesn't work that way with anybody. And I think one of the things that we have to accept is just do our best. If something doesn't work out, we want to do what's best for the patient. We have to redo something or change something. And, it may not be the most efficient way to practice that day, but when we go to bed, knowing we did our best for our patients, I think that's the best we can do. Take the stress off of ourselves that we have to be perfect. I think that's kind of ground into us in dental school. And maybe some of us are OCD just naturally. That's why we went into dentistry. But I think we have to allow ourselves to accept that, we all are human. We need to enjoy our lives. We can't take that stress from the office and, spread that over our families at home. So, I think that's why what you do is so valuable, because you're able to share ideas and different viewpoints with our colleagues. And one of the things you find out is that we all do have different viewpoints. Like one of your past guests talking about occlusion and how there's all these different camps out there. And, he's absolutely right. But when I'm talking about occlusion, because it's one of those things that I teach too, I try to tell the doctors, hey, instead of arguing amongst each other, why don't we find the commonalities in occlusion and start to apply those and learn to accept that how I treat occlusion may not work in your hands. It doesn't mean that, you're not a great dentist. It doesn't work for you. It's like placing a composite. The way that I place a composite may work great for you, it may not work great for you, but you'll find that recipe that works in your hands. And if you follow that, you're going to probably have success. So I think it really is accepting ourselves and accepting our colleagues.
Oh, that was, so well said. And I think you had so many good points there. And it's so true. Like you said, you travel to Russia and you meet dentists. We're all living these parallel lives that, kind of going through the same thing. And a lot of us, especially the solo practitioners, we're stuck in our own little bubble. And I think it's so important to engage with your peers, find mentors, because there's nothing more enjoyable than, chatting with another dental professional and kind of just sharing stories. And you realize you're not the only one going through this.
Mm-hmm. I think it's honesty too, right?
Yeah.
Because, a lot of times if we share stories, we can talk about things that maybe didn't work out perfectly. But if we're always telling our colleagues, yeah, every filling I place lasts 20 years and without exception, it just makes the other colleague feel bad. And I think truthfully, we know that that's probably improbable as a goal to have every restoration be perfect for 20 years. So yeah, we've got to be truthful to each other and just be human.
Yeah. And, and this is hard to do. It can take a while, but I used to focus on the one bad thing that happened during the day, the one negative or uncomfortable conversation, and I wouldn't enjoy the 30 great things that happened. So if you can get over that and focus on the good things that happened, the people that you helped, the procedures that went awesome, not the one bad filling you did or, uncomfortable patient experience, you're going to live a longer, happier career. And it's funny you said your dad was a dentist, and my dad was a dentist too.
Yeah.
But I went to Tulane not wanting to go to dental school, and I one night missed my mouth with a beer bottle and hit and fractured number 9.
Yeah.
And so I was walking around that night with half a tooth. So I went to a local dentist in Metairie, Louisiana, because I went to Tulane in New Orleans, and I walked in with half a tooth and didn't want to smile, and I left, with my smile again. So that's kind of how I got into dentistry, and then I started hanging around my dad's office. So we had kind of similar stories there, except mine was a beer bottle to the tooth.
Yeah, that's cool.
So I want to, Mike, this was an amazing episode. I wanted to just ask you one final thing before you wrap up. If you could talk to young Mike, 20, 30 years ago, what would you tell him?
I would just say, stay curious and open-minded. I think in my 30 some years, I look back at it. I remember when I got out of dental school, and my father at that point, I think, had been working 25 years or so. And I remember thinking, I don't know how anybody could do this job for 10 years, right? And then I hit 10 and 20 and 30 years, and I go, wow, now I can't see not doing what I do. But, I run into colleagues, and they're kind of burnt out, and I know a lot of dentists are, and it's because you get on that treadmill. You're just doing the same thing every day. And, in my career, I look at every day as full of possibilities. What can I learn today? How can I change this? How can I change that? And in teaching, and a lot of the teaching I do is live patient, where we have doctors bring their patients in. So I get to see these clinicians working in their own style of dentistry. And we're trying to change them to do it maybe a different way, but we all get stuck in our comfort zone. And I watch them, and I see all these habits that they pick up, or maybe some materials that I haven't seen for decades. And I go, why are you using that? And I go, well, this is what I learned in dental school. And I go, well, so you haven't changed anything since dental school? No, because this is the way we were taught. Mm-hmm. And I think, with all the innovation that we have, like talking about the adhesives and the flowable composites, it's so different than what I was given and shown how to use in dental school. I can't see doing dentistry the way I did 30 years ago today. And I think I would be burnt out. I think I'd be frustrated, and it'd be too boring. And today in dentistry, there's just so many new things. And you've got the CBCT. We're placing, I teach dental implants, and we're doing minimally invasive dental implants, and we teach endo, and now it's minimally invasive endodontics. And things like this, regenerative restorative dentistry. There's so many exciting things going on that don't get stuck. I see a lot of kids coming out, and it's different than when I came out. So I see a lot of kids that are coming out, and they go into the corporate practices. And I'm not knocking corporate practices. They got the business model, and they're highly successful. I get that. And they help the kids get started. But a lot of them, and I hate to generalize this, because there are some great ones that are very progressive. But a lot of them just try to create cookie cutter practices, where they're just doing fillings and crowns and things like that. And I can see kids just kind of getting stuck there and getting bored and burnt out. And I think that's a great place to start, get proficient at the bread and butter dentistry, but then always look at the other things that are out there, using lasers, using CBCT and placing implants, and doing some of the fun things like the aesthetic dentistry that's really fun. And patients will thank you for doing that kind of dentistry. When you do the root canal, you could have done a beautiful root canal, but the patients don't see it. But when you do a veneer case and they look at their smile, we had a patient that we just saw on last Thursday, and we had just done a smile makeover on her last year. So we were kind of doing a follow-up with her 6 months out. And she goes, I just love smiling every day because I love my smile. And those are great things to be able to experience. So stay on that educational forefront. Keep open-minded. The way you do things today, you don't have to do it the same way tomorrow, because there's always new innovations. Stay on top of that and just enjoy it. Build relationships with your patients. I tell people, I don't go to work. I go to work, my workplace, just to hang out with my friends and family. The people that I treat, I consider my family. And so it's just really fun and enjoyable day. And it doesn't mean I don't have my difficult patients or my difficult procedures, as you were mentioning. But, we just do our best. And I think we're talking about it. I mean, if you have to redo something, it's not the end of the world. I had one mentor, Dr. Jenkelson. He said, you have to remember, patients aren't machines. It's not like we drill out a piece of metal and replace that metal with a bolt or something like that. We're working on biologic beings. The way somebody heals isn't the same, between individuals. The way somebody chews isn't the same. I mean, there's so many variables that we have to accept that we can't control everything. And I think that's one of the things we as dentists think is we think everything is mechanical. When you go back to occlusion, we think everything is mechanical, and it's not. We've got personalities behind that tooth and that jaw movement. We've got stresses. We've got medications that influence what the patients are doing. So, again, to be more stress-free, I think we have to accept all the different variables in life, and stay on that path of education and just being curious about your profession. If you do that, then every day you wake up, you're going to be excited to get out of bed and go to work.
That's so, you made so many good points there. And I totally agree with you. You don't want to get stuck in that hamster wheel, adding new techniques or technology to your practice. I call it return on fund versus return on investment, even if it's a little more expensive, but if it makes you enjoy going to work, like the CBCT and the digital implant guided surgery flow that I have, I love doing implants, and it's become one of the most enjoyable procedures that I do. We just also after COVID, we switched from polyvinyl impressions to a trio scanner. I love doing crowns again. So if you start adding these other techniques, technology, modalities, you're going to avoid burnout. So Mike, thanks so much for such a great episode. I think that you said so many powerful things. Again, Dr. Michael Miyasagi, he's the COO and CDO of Vista Apex Dental Materials, and you can go to DealsForDentists.com and you can get 10% off the Pink Wave and some of the regen materials. You can find that under the equipment and supplies category. Mike, thanks so much for joining us.
Hey, Eric, it's been great to be with you and our viewers. Thank you very much for this opportunity.
You got it. We'll be in touch.
All right. Thank you.